manic, hypomanic. But what is the burden of bipolar depression? It is actually it is a progressive disease and it is a complex phenomenon. In fact, what we have encountered in our clinical practice, bipolar depression is one of the toughest case we encounter. And there are no accepted diagnostic criteria for bipolar depression different from major depression. Why focus on bipolar depression? Because the time depressed is 3 times more than the time manic. And depression is correlated with increased disability, suicidality, and medical comorbidities. A number of depressive episodes correlates with the degree of cognitive impairment, and antidepressant is not effective at all now, says, in case of bipolar depression. Or there is a chance of switching to mania, more chance. This is a pictorial presentation of the prevalence of the depressive symptoms. In bipolar 1, you've seen that it is 67% period is depressive phase, and in bipolar 2 it is 93%. And percentage of the patient reporting attempted suicide while depressed, it is this data collecting from the Stanley Center Bipolar Disorder Registry, round about 2,839 patients. It is seen that 92% of the patients attempted suicide while they are depressed. And in other study also there is 79% of the depressive episode patient commits attempted suicide is after the manic episode in the depressive phase. This is also shows that the relapse of depression in bipolar disorder. It is seen the number of depressive episodes ultimately having the poor prognosis. That is the 1 to 5 previous episode of depression are 60% more likely to respond treatment versus with the greater than 10 episodes. That means less episode is good. And bipolar disorder, there are some diagnostic issues definitely. The onset of the bipolar disorder is usually insidious and begins with the depressive symptoms. And that's why it's very difficult to diagnose whether it is bipolar disorder or major depressive disorder. And initial depressive symptoms are quite often and misdiagnosed as a major depression. And it is not uncommon for a diagnosis of a bipolar disorder to be delayed for up to a decade or more. There are some points to compare with the depression, bipolar depression with the major depressive disorder. If you consider the phenomenology, the symptoms are atypical, irritability is there, melancholia is there, psychomotor retardation and agitation and psychosis is more common. Regarding the course of the illness, episodes of depression are brief, occur at an early age, and have a pattern of recurrence or rapid cycling. And response to treatment, tolerance is more common and more chances switching to mania and rapid cycling to mixed state. But after all, clinically I am telling, in our practicing level, it is very difficult to differentiate. It is theoretically possible to these points, but clinically, not only clinically, in diagnostically, your depressive symptoms are diagnosed as a depressive criteria, major depressive criteria. Course of illness in a true bipolar disorder, there are 60% of cases have the substance abuse and half of the cases have anxiety disorder and psychotic features. You know that depression is more common in bipolar depression with psychotic symptoms than major depressive disorder. And there is also work disruption, hospitalization and suicidality is there. In fact, 15 to 20% reported that eventually complete suicide, 15 to 20%. Another comorbidity like overweight, obesity, metabolic syndrome, dyslipidemia, type 2 diabetes mellitus, cardiovascular disease, hypertension, stroke. I told you earlier that psychosis is more common in depressive disorder. That is 50 to 75% of the patient with bipolar disorder experience delusion and hallucination with 90% of the lifetime prevalence. And in psychotic symptoms, hallucination is very less common and more common is nihilistic or paranoid delusion. And postpartum psychosis is a strong predictor of bipolar depression. In some studies indicates like this. This is also another slide which shows that time to recurrence of depression is shorter in obese patient than compared with the non-obese patient. So obesity is the main factor we should treat simultaneously for obesity. This is a neuroprogression in the bipolar disorder. You know that the recurrent mood episode which causes the cell damage, oxidative stress and inflammatory cytokines. These all causes the cell damage and the structural changes. Then it becomes treatment resistant and decreased coping and kindling and life stressor, and then again mood episodes. It's a vicious cycle basically. What are the treatment issues? What to do in case of bipolar disorder? Main aim of the treatment is to ameliorate the depressive symptoms and establish the maintained mood stability. Mood stabilizer like lithium, valproate, carbamazepine play an important role in the treatment of mania and hypomania. Standard antidepressants are poorly suited for the controlling bipolar disorder because they can cause destabilization of the mood and induce rapid cycling 3. And effectiveness of the atypical antipsychotic in maintenance therapy is constrained by potential for significant side effects of individual agents and lack of both long-term research data and clinical experience in treating bipolar disorder as compared to other agents. You see that regarding the treatment of the acute depression in bipolar disorder, till 1990, there is no molecule. After that, olanzapine fluoxetine combination comes and quetiapine comes. It is after 1990. An evidence-based treatment for acute bipolar disorder shows that olanzapine fluoxetine comes in 2003, quetiapine and comes 2008, and XR preparation 2008, and lurasidone comes latest 2013. These are the year when comes as a lithium as a mood stabilizer for bipolar disorder. 1974 is lithium and latest is quetiapine 2008. This is a CanMed study, which is a Canadian network for mood and anxiety treatment. This study is supported by Canadian that group and also International Society for Bipolar Disorder. Both they promote this study. They suggest that first line of the treatment is monotherapy, lithium, lamotrigine, quetiapine, XR, or combination therapy like lithium or divalproex plus SSRI. But in case of SSRI, they still say paroxetine should be avoided. And olanzapine and SSRI, lithium, divalproex, there are so many combinations. And second line, they added lurasidone. And third line, most interestingly, they add ECT, electroconvulsive therapy. But they also mentioned you can use ECT in any stage if you think it is needed. There is a high suicidal probability. This is the maintenance therapy. I think Abhay will tell elaborately for this. And recommendation for maintenance treatment for bipolar 2 disorder. This is the first line treatment, lithium, lamotrigine and quetiapine. Second line, divalproex, lithium, divalproex or atypical antipsychotic plus antidepressant. And adjuvanting quetiapine or adjuvanting lamotrigine is a combination of two of lithium or divalproex or atypical antipsychotic. And third line, the same or carbamazepine, oxcarbamazepine, atypical antipsychotic, ECT or fluoxetine. And olanzapine. And gabapentin is not recommended in any phase of the treatment. Pharmacotherapy, This is bipolar depression. Antidepressants, quetiapine, olanzapine, fluoxetine combination, lamotrigine, lithium, valproate, carbamazepine as a mood stabilizer, and may add thyroxine if needed. This is the treatment response. It is shown that the 600 milligram quetiapine is very good responder than placebo, and lamotrigine 200 milligram, higher doses they act better. And olanzapine fluoxetine combination is very important, and lithium also very important. And there are also novel options. The newer is lurasidone, agomelatine, atypical antipsychotic like risperidone, olanzapine, aripiprazole, clozapine, pramipexole, modafinil, methylphenidate. Repetitive transmagnetic stimulation is also one of the important mode of treatment. Some data shows positive news, and vagus nerve stimulation, deep brain stimulation, light therapy, sleep deprivation, ketogenic diet, omega-3 fatty acid. All these are the other options, but not advocated very frequently, just because it is not. The day will come, it will say whether it is effective or not. Lurasidone is actually strong